Welcome. This is Pediatric Hematological Cancers. Common hematologic cancer, childhood cancers, our three most common types are leukemia, Hodgkin's lymphoma, and non-Hodgkin's lymphoma. Nurses really need to be able to recognize unique manifestations of each condition, anticipate complications and side effects of therapy, provide appropriate condition-specific nursing care, and support children and family through the diagnosis, treatment, and recovery. So we're going to start with leukemia. Leukemia is the most common childhood cancer, especially for children less than 15 years old. Causes, so this is an abnormal proliferation of white blood cells, specifically the blasts. Blasts compete with normal cells for space and nutrition. This results in suppression of bone marrow production of other cells. So your clinical consequences, we're going to end up having anemia from reduced red blood cells, thrombocytopenia from reduced platelets. Treatment advances have improved overall outcomes. Acute lymphocytic leukemia, ALL, is the most common form. Nearly all children can retrieve remission. A 5-year disease-free survival rate is about 85%. So let's go into the etiology and pathophysiology a little bit more. Leukemia most often develops from a genetic defect that disrupts normal white blood cell maturation. The malignant white blood cells replicate rapidly, producing large number of immature blast cells in the bone marrow. These blast cells ignore normal feedback mechanisms and continue uncontrolled replication. Blast cells then spill into the peripheral circulation and are detected on a complete blood count, so a CBC. As blast cells crowd the bone marrow, production of red blood cells and platelets are slowly suppressed. This results in anemia and thrombocytopenia. Leukemia cells can infiltrate other sites. Most often, we see central nervous system complications and also in the testicles. Clinical symptoms are due to combination of the bone marrow failing and the organ infiltration. Leukemia is classified by the type of white blood cell affected and the onset of symptoms. So we can have acute leukemias, which would be acute lymphocytic leukemia, ALL, and this is those abnormal lymphocytes. We can have acute non-lymphocytic leukemia, ANLL. This leukemia is not originating from abnormal lymphocytes. There's AML, which is myeloid cells. And then we can also have chronic leukemias that kind of have a slower onset of symptoms, where we can have chronic lymphocytic leukemia and chronic myeloid leukemia. This is just a little picture of all the different sites that can be affected by this. When we talk about stage 1, the colors of stage 1 is where we're going to first pick it up at. And as we infiltrate into more systems, stage 4 would be the most significant, and that would be that it's impacting to bone. So again, remember, if you listen to the first lecture and we talked about the difference between cancer growths and just benign growths, cancers start to infiltrate other tissues and systems. So once we get to the final stage, it's usually either to bone or brain is where it's at. So our clinical manifestations, signs that you should really know is that the kid's going to have petechia, pallor, bruising, fatigue, and anorexia. Additional clinical manifestations, we can have fever that's usually reoccurrent or persistent. Bone and joint pain, commonly in the legs and knees. We can have enlarged lymph nodes, malaise, hepatosplenomegaly, and then, of course, our abnormal labs where our white blood cells are going to be high and our platelet counts are going to change and we're going to have red blood cell change. So, diagnostic evaluation. CBC, so first, we're going to go with our initial suspicion, and that's going to be based on the history and the child's clinical manifestations. And then we're going to get into lab work. So the CBC would differentiate. We're going to see a reduced hemoglobin, a reduced platelet, a reduced white blood cell, but an increase in our lymphocytes. So our baby cells are going to be high, and our mature white blood cells are going to be low. Additional diagnoses, we're going to be having elevated uric acid levels from the cell destruction. We're going to do bone marrow aspirations and biopsies. And when we do that bone marrow aspiration, we're going to see those blast cells, and we're going to see a lot of them. We can do a lumbar puncture to see if we have central nervous system involvement, because we know that that's going to be a later stage. And then symptoms, headaches, nausea, vomit, altered mental status, can all happen from the lumbar puncture. We can also do flow cytometry, which is a laser analysis of marrow cells. It kind of classifies the type of leukemia, and it'll detect chromosomal changes, which is important for prognostic indicators. So a really quick leukemia wrap up, right? Again, the definition of this is an uncontrolled proliferation of white blood cells, which will lead to cellular destruction from infiltration into body tissues. Your primary consequences are going to be anemia from red blood cell destruction as well as bleeding, infection due to neutropenia, and bleeding tendencies due to thrombocytopenia. Acute lymphocytic leukemia is the most common in children. It involves those blast cells. Common symptoms are fever, pallor, fatigue, anorexia, petechia, hemorrhage. Your nursing care for this. So focus overall is going to be preventing infection, preventing bleeding, and managing treatment side effects. We want to make sure that we're performing thorough and routine assessments. Childhood history is often going to show a very slow, insidious onset where we're going to start with kind of reduced activities. Then we're going to have these frequent fevers. Then we might have like bleeding and stomach aches and painful extremities where they can't walk. Again, the leg pain could be misinterpreted as growing pains. I have a story, but I'll tell that in class. We want to consider age, development, and past experiences with healthcare providers. Physical exam will review fever, pallor, bruising. They might have petechia just in the mouth or in the sclera. We're going to see hepatomegaly when we're doing our abdominal assessment, and we might have reports of unusual bleeding. If we have neurological involvement, right, we know that this is a worsening of it. So we would monitor for central nervous system infiltration. If they're having like headaches, nausea and vomiting, changes in mental status. The cocktail for that is intrathecal chemo, methotrexate, critibine, and hydrocortisone. And all of those are given to prevent central nervous system involvement, because once that gets involved, prognosis isn't as great. We want to provide psychosocial assessment for the children. We want to assess coping strategies. We want the parents to not have as anxiety if we can. Good support, good coping. We want to help them out with that. So nursing interventions, right? If you're looking at, okay, I have a kid who can have infection, you're going to be monitoring vital signs. You're going to be looking at lab values. You're going to make sure if they become neutropenic that you put them on neutropenic or reverse isolation precautions. Checking their skin, their mucous membranes, are we having any signs of breakdown? Encourage monitoring of, like how's their bowel habits, how's their dietary habits. Lots of mouth care. We want to be doing mouth care 4 times a day. We want to administer antibiotics as ordered. Um, Oral hygiene, hand hygiene. Um, Basic outcomes of that, the child should remain afebrile, no redness or swelling, negative cultures. Child can tell you recognitions of early signs and symptoms of infection. When we're looking at bleeding, right, we want to monitor for signs of bleeding. So, mucous membranes are usually big, so nose, gums, urine, also stool. We want to make sure that we limit high risk activities. So anything that could provide a head injury or another injury, they're at risk for excessive bleeding. Um, if it's a female and she's still having a menstrual cycle, like assessing what that menstrual cycle flow is like. And then, like education, like when they're blowing their nose, like not to blow hard because they could develop that bloody nose. Education on how to control bloody nose if they get that. When we're looking at nutrition, we want to make sure that we're administering prophylactic and PRN antiemetics. So Zofran, Reglan, Phenergan, something that's going to stop them from getting nauseous from their treatments. IV fluids for dehydration. Again, cool, bland, soft diets. They might require parenteral nutrition. We want to encourage high protein, high calorie. If they're having mouth pains, we want to give analgesics before meals so that they can get their meals down. Good monitoring of INOs. We want to involve the child in their food choices. This is a good time to collaborate with dietary. And then altered body image, education on hair loss, what we can do for that, encouraging verbalization of feelings about it, suggest coping strategies, early return to school when possible. Um, so those are some ideas for nursing interventions. Education, so general education, you want to reinforce the diagnosis, the treatment, the side effects, encourage the parents to actively participate in daily care. You want to do written and verbal instructions. You want to teach and demonstrate care. If they have a central line, are they able to perform dressing changes? Are they able to make sure that the child can clean themselves and keep the line safe? What's their oral medication? Do they have the correct administration techniques? Checking that mucosal membrane or any type of irritation or bleeding, recognizing signs and symptoms of infection and bleeding. Ensure that parents return demonstration, right? So when you're saying this, showing this, educating it, make sure you get that confirmation that they understand it by either return explanation or return demonstration. A lot of supportive resources out there. So make sure that they have referrals to social services, spiritual support, home health, community resources. Really stress the importance of infection and bleeding prevention, as well as follow-up care, and knowing that they have their contact numbers for urgent and emergent questions. Now we're going to talk about tumor lysis. So tumor lysis is a life-threatening complication that can occur within hours after treatment. It's the cause of rapid breakdown of cancerous cells, which then release toxins and chemicals into the bloodstream. It affects heart, kidneys, and muscles, and it can progress quickly into a medical emergency. Prevention of this is good IV hydration, because that's going to promote urine flow and removal of the toxins. We can use medications to prevent crystal formation in the kidneys, and we want to identify high-risk patients before starting therapy. So our treatment, if they go into it, is obviously going to be fluid, fluid, fluid. We want to use diuretics to increase urine output. We want medications because they're going to end up with high potassium and high phosphorus levels. So we need things to reduce that, medications to break up kidney crystals, and they might actually require dialysis if it's severe enough. So prevention is key. Good IV hydration beforehand is important. So I was talking about chemotherapies, and before we do chemotherapies, we want to make sure that we're hydrating them. We want to make sure that we're checking their labs, and we also want to make sure that we're giving them anti-nausea medications. Hodgkin's lymphoma. So this often presents as a localized disease. Um, Systemic symptoms are kind of used for staging. We might have unexplained fever, weight loss, night sweats. So the pathophysiology, it originates in one lymph node or group of lymph nodes in the same region. And then we have these Reed-Sternberg cells that are present. And they have giant multinucleated cells, and it's believed to be activated by B and T lymphocytes. It does have a predictable spread where it starts at the lymph nodes, goes to the spleen, liver, bone marrow, lungs, and then to the mediastinum. The etiology, exact causes unknown. We do think or see that there might be some possible infectious associations. So after kids have herpes virus, cytomegalovirus, or Epstein-Barr virus, we can see these infected Reed-Sternberg cells that play the role. So what are our clinical manifestations? Local signs, we're going to see painless, firm, movable adenopathy in the cervical and supraclavicle regions. If we have medial Steinman involvement, we are concerned about airway obstruction. Systemic symptoms will be fever. They might be complaining of like drenching night sweats where they're just waking up and very wet. Unexplained weight loss. Other findings, we can have hepatosplenomegaly, jaundice if we have liver involvement, fatigue, and anorexia. Diagnostic evaluation in Hodgkin's disease, so confirm tests. We're going to do a lymph node biopsy, and that's going to show us the presence of those Reed-Sternberg cells. We can do laboratory studies, CBC, kidney function, liver function, sed-rate levels. Sometimes they'll do like a serum copper and a serum ferritin, and that's just to help with prognosis and follow-up. Imaging scans, gallium scans, PET scans. Remember that gallium scan evaluates the disease extent. Chest x-rays and CAT scans can assess for how far it's spread. We can do bone marrow aspiration, so bilateral bone marrow aspiration and biopsy. And usually this is only if it's type 2 symptoms are present. So nursing care of patients with Hodgkin's lymphoma, we want to do therapeutic management. Therapy depends on the child's age, diagnosis, disease stage, and histological type. Your nursing considerations, like what's your kiddo's activity level? Are there lymph nodes with lumps? How's their airway patency if we have mediastinal involvement? Respiratory system for changes in status. After the diagnosis, you're going to be doing IV line access. You're going to be giving medications and treatments as ordered. Non-Hodgkin's lymphoma differs greatly from Hodgkin's. The mode of metastasis and the responsiveness to therapy. This disease has a rapid onset with widespread involvement, that's usually at the time of diagnosis. So the etiology, the exact cause is unknown. We also think that it's influenced by like a viral, immunological, or a genetic predisposition. Our high-risk kids are going to be kids with congenital immune deficiencies, AIDS, somebody who's had an organ transplant, kids that are on immunosuppressive agents. Um, what are we going to see? Our clinical manifestations. Abdominal disease is common presentation. So, cramping and constipation, pain, anorexia, weight loss, ascites, obstruction, and vomiting. Lymph node involvement, which will be painless and large lymph nodes in the cervical, axillary regions, can be inguinal, but that's less common. Mediastinal disease is going to show cough, respiratory distress, and symptoms that almost mimic bronchitis. Late sign would be tracheal deviation. Bone marrow involvement leads to a general decline in health. Bone marrow suppression will affect your white blood cells, red blood cells, and platelets. They'll all be low. Diagnosis. So uric acid levels are going to show elevated levels, which is going to indicate rapid growth and destruction of cells. Lymph node biopsies will confirm pathological findings. Chest x-ray will look at the trachea deviation as well as identify if we have mediastinal disease. CAT scan of the neck, chest, and abdomen will also give you the evaluation and the extent of the disease. Bone marrow biopsy and aspiration will show if we have involvement of the bone marrow. Lumbar puncture will assess if we have central nervous system involvement. Overall focus, identify symptoms early, prevent and recognize tumor lysis syndrome, and manage treatment and side effects. Your nursing assessments are going to be for behavioral change, abdominal pain, lymphopathy, respiratory compromise, ill appearance, and electrolyte imbalance that includes increased uric acid, potassium, phosphorus, and reduced calcium. Nursing interventions, we want to maintain stable metabolic state before and during chemotherapies. We want to monitor our INOs and our serum chemistries. We might need to give this child a urinary catheter for just a really good INO output. With any fever, you want to obtain blood and urine cultures. We want to make sure that we're providing nutritional support. It can be enteral or parenteral. Treat respiratory distress immediately. Obviously, if we're having tracheal deviation, that's going to require intubation. Provide intense IV hydration therapy. Prevent uric acid crystal formation. Ensure IV fluids contain new potassium. Administer allopurinol to lower the uric acid. Monitor for serum electrolytes. Evaluation of these interventions, right? Our child should maintain a stable airway, stable respiratory status. Our vital signs should be good. Our urine output should be age appropriate. And our parents should be engaged, asking questions and demonstrating their understanding of care. That is the end of this lecture. The next one will be on solid tumors.